think the chairpersons can make a start.
Now start, sir.
I think you can start. It's exactly
Yes,
exactly 1:30 in Lahore. That is 2 o'clock India time. You can start, Prasanna.
Yes, so it is 2 o'clock now. I'll share the screen now with my presentation.
Good afternoon, everybody. Can you hear me?
Yes, can hear you.
Good afternoon, sir. Sir, I would like to welcome all of you to this session on expert talks. This session is sponsored by and we have 4 speakers who will be talking about various topics. We have Dr. P.K. Reddy who will be talking about pancreatic neuroendocrine tumor, followed by Dr. J.K. Jameel, who will be talking about laparoscopic management of. We have Senthilnathan, who will be talking about laparoscopy for chronic pancreatitis. And finally, Dr. Reddy will talk about political cysts in adults in the laparoscopic era, rewards, overcome the challenges. Now, for the chairing the session, I would like to call upon Dr. Muhammad Arshad Chima from Pakistan, Dr. J.A. Jailal, and Dr. M. Senthil to take over the session and call on the first speaker.
Okay, I think Professor Reddy is already, he's ready with his first slide, as I can see it. So so Professor Reddy will start the first presentation on pancreatic neuroendocrine tumors. Over to you, Professor Reddy.
Thank you very much, sir, and Mr. Chairpersons and friends. Good afternoon and good morning to everybody. I thank Dr. Professor Raman Goyal and Professor Griffin for organizing this INDO-UK SURGICON 2020. It's really immense pleasure to participate in this. And my talk is on pancreatic neuroendocrine tumors, which is not a very common entity. But of course, in the recent period, because of the availability of the various imaging modalities and the endoscopies, and more than that, among the medical community, the awareness has increased. That's how we are able to see more and more of the pancreatic neuroendocrine tumors nowadays. This is a picture where I have put it as I have operated number of luminal neuroendocrine tumors as comparatively with the pancreatic neuroendocrine tumors are very less. And which itself was, as I mentioned, these tumors are not common, they are the rare. They are the somewhat rare entity. The pancreatic nets, which are popularly called as PNETS, they arise from the pluripotent stem cells in the pancreatic ductal acinar system, and they account for about 1% of pancreatic cancers. The peak incidence is 40 to 69 years. As per the SEER database, 73 to 2000, annual incidence per million was 1.8 in women, 2.6 in men. If you see there are various classifications of these tumors. One of the classifications, depending on the characteristics and functions. So functionally, these are classified into non-functional, functional category. Non-functional, why I said was non-functional accounts for about 90% of the tumors, whereas a functional accounts for about 10% or less. And the division is non-functional, they don't exhibit any symptoms till they become large and cause the compressive symptoms. And the prevalence of metastasis is high, is more than 50% because they stay longer time and without the knowledge of anybody, unless they are detected accidentally. For a functional tumors, they produce all this all these are functional tumors, the commonest being the insulinoma, and it is account for about 1 to 2 per million, and it produces insulin and produces hypoglycemia. And if you see the metastatic potential as insulinoma is concerned is very less, that is less than 15%. Whereas the next common one is the Gastrinoma, accounts for about 1 to 1.5 per million. It's very rare tumors, and the metastatic potential is less than 50%. Like this, other hormone like glucagonoma, lipoma, and somatostatinomas, these are all the very rare tumors. There is another classification given by the World Health Organization. The World Health Organization has graded them into grade 1, 2, 3. Grade 1 are well-differentiated tumors. The Ka67 proliferation index is less than 3, and the mitotic index is less than 2. Whereas the grade 2, they are well-differentiated to moderately differentiated tumors. The Ka67 proliferation index is 3 to 20%, and whereas mitotic index is 2 to 20. And grade 3 PNETS are, in fact, actually they are neuroendocrine carcinomas. They account for about more than 20%, and their mitotic index is very high, more than 20. And whereas there is another classification which is commonly used is the AJCC, that's American Joint Cancer Committees in 2014. They formed a TNM classification. According to TNM classification, that is tumor node metastasis, there are 4 stages, and these are supposed to indicate the prognosis for all these tumors. But no staging system, no classification is perfect as far as the prognostication is concerned in the PNETS. Interestingly, PNETS are found in the inherited disorders. If you see here, for example, MEN1 syndrome, the frequency of NETs are 80 to 100%. So multiple endocrine neoplasia 1 syndrome. And there again, 2 types, non-functional and functional. In this, gastrinomas are more common, and the other thing is they are small and they're more malignant. They're more than 1 in the pancreas normally. Now, what are the biochemical investigations which are available for the diagnostic purposes and for the monitoring purposes? Chromogranin A, which is a very important antigen, what is available, and it indicates tumor burden, used as a marker in both functional and non-functional PNETs, post-treatment used as a prognostic marker. That's one of the advantages of chromogranin A. And pancreatic polypeptide used when CGA is negative. And pancreatitis, post-translational product of chromogranin A, and it is more powerful prognostic test than in PNETs. Other one is neurokinin A and synaptocin. These are more diagnostic rather than prognostic. The most important thing which has come is, as I mentioned in the beginning, and the imaging systems. We use the ultrasound, CT scan, and MRI. And CT scan is the one which is most frequently used. And whereas the other test is a somatostatin receptor scintigraphy. It is an interesting thing actually. Why interesting is, all the neuroendocrine tumors have got the somatostatin receptors. If you inject the octreotide, it goes and gets locked into the somatostatin receptor site. That's why it is a very, important test in the diagnosis of somatostatin in neuroendocrine tumors. Other things, endoscopic ultrasound. Now we have the endoscopists available who does these tests very well. In more than 90% intrapancreatic NETs, they'll be able to pick them up. And intraoperative localization, some of them in my experience, particularly for the head tumors, I was using both in open ultrasound probe as well as the laparoscopic ultrasound probe to detect these tumors, particularly in the head. We don't have much of a problem as far as the body and tail are concerned, but the head is concerned is important. That's where the endoscopic ultrasonography is useful to take a needle biopsy or even to inject the chemotherapeutic medicines into the head of the pancreas. Of course, the latest treatment investigation is the PET-CT, that is 68 rotatate PET is available. It is useful mainly in those cases which are that is undifferentiated tumors. These are not very much useful in differentiated tumors. And what is the preoperative management of these tumors are concerned? You treat the symptoms of hormonal excess. That is the important thing, using the octreotide or lanreotide. And insulinomas, you stabilize the glucose level. Gastrinomas, use the proton pump inhibitors. And glucagonomas, treat hypoglycemia or hyperglycemia. I'll be talking a little later. And preoperative trivalent vaccination in these cases is advised. And what are the surgical principles for management? You localize the tumor and then resect it. And peripheral insulinomas and small, that is, size of the tumor is very important, as you have seen in the AJCC classification. Size of the tumor, 2 centimeters is very important. Less than 2, non-functional, you do either enucleation or a pancreatic, or a distal pancreatectomy. Even in the head, I have done about 4 cases of enucleation of these insulinomas from the head of the pancreas, enucleation. And larger tumors, more than 2 centimeters, are malignant appearing, non-functional, and the functional PNETS, you need a total resection, and plus regional lymph node lymphadenectomy. Now, overview, if you see the locoregional disease, non-functioning tumors, the size of the tumor, less than 2 centimeters nucleation, more than 2 centimeters radical resection. In the functioning tumors, gastrinomas, and you do PPI, octreotide, lanreotide, and then take them up for surgery. And insulinomas, glucose control given by diet and diazoxide and surgery. And glucagonomas, glucose control and fluids in the surgery. One. Next comes to the insulinomas. Insulinomas is a locoregional disease. How do we approach? Exophytic peripheral tumors, no problem. Nucleation or laparoscopic resection. Deeper or invasive tumors, head pancreatic duodenectomy or distal pancreatectomy or the procedures. In gastrinomas, as we discussed, more or less the same. Occult or no primary or metastasis on imaging, observe. Or exploratory surgery and then do an intraoperative ultrasound and check them out. If they are exophytic or peripheral tumors, enucleation plus lymph node dissection. Deeper or invasive ones, once again, radical resection is the treatment. And non-functional PNETS, once again, it's the same. If it's less than 2 centimeters, enucleation, regional lymphadenectomy. If it is in the head, and if it is in the body and tail, distal pancreatectomy, regional lymph nodes plus venectomy. And if it is more than 2 centimeters in the head, pancreatic duodenectomy and regional lymphadenectomy, distal pancreatectomy for body tumors. And the NCCN guidelines have very clearly said, what do you do for unresectable disease and or distant metastasis? They have given very clearly, there are 3 categories. 1, if complete resection is possible in the unresectable disease, resect metastasis and then primary. And then the second one, asymptomatic, low tumor burden, that's Ka67 and the mitotic index, and stable disease, observe with markers and scans every 3 to 12 months. Consider treatment with octreotide or lanreotide. Third category is symptomatic or clinically significant tumor burden or clinically significant progressive disease. Manage clinically significant symptoms as appropriate and then go on to the consider octreotide, lanreotide if they are receiving, all right. Otherwise, you go for the everolimus or sunitinib or cytotoxic chemotherapy. Otherwise, hepatic regional therapy by way of arterial embolization or chemoembolization, or now the present radioembolization, that's the PRRT, that is you inject the radioactive spheres into the system, into the liver. So finally, if nothing is, you do the cytoreductive surgery or ablative therapy to give them a better period of long time, as long as they live. So what is the role of laparoscopy in PNETS? This paper clearly shows the laparoscopic surgery for PNETS is feasible with acceptable morbidity and a good overall disease-specific long-term prognosis. Another paper, once again, shows it's a meta-analysis just done. The nature of this meta-analysis is limited. Nevertheless, laparoscopic pancreatic surgery for PNETS appears to be safe and is associated with complication rate, less complication rate and shorter length of stay than open pancreatic surgery. And you can see here, this is small enucleation. This is a small, this is how the pancreatic enucleation is done. 1 millimeter is sufficient. Away from it, you can do it. I'll just show a little bit of this one if the time permits, I'll do. Otherwise, I'll just make a little bit of a compromise. This is, as we've done this, it will show EUS-wise a hypoechoic lesion. This was a 4 to 4 centimeters in the tail of the pancreas. FNAC is suspicious of a neuroendocrine tumor. And you can see here when that's the tumor there. That's the tumor which is in the tail. You can see it better in that is the one. That's the tumor, and at the tail of the pancreas. Then I've done the resection of this by after resecting the pancreas. I tried first to do the spleen preserving distal pancreatectomy, but as the tumor was very much stuck at the splenic area, I did a formal distal pancreatectomy by doing this, by removing the spleen as well. So, in summary, PNETS are relatively uncommon tumors of the pancreas, heterogeneous disease. Hormone production can often help in diagnosis, better prognosis than adenocarcinomas. Only curative treatment is surgery, either a radical resection or enucleation. Enucleation has got a small problem because these pancreas with the PNETS, the body is soft, and the ducts are not dilated. The chances of producing the fistula is higher. There is not a widely accepted staging system. Tumor size, location, histopathological behavior, that is Ka67 and mitotic index, determine both the surgical treatment and prognosis. Thank you very much.
It's a great honor to hear from Professor Prasanna sir, and he is a master of both endocrine and open surgery. And it is really every single word he has said is the words of wisdom. It is a huge topic which he could cover within a short time. I'm sure it is a great feast for us to listen to your lecture, sir. Okay. Thanks a lot for your excellent lecture.
Thank you very much.
Mohammed sir, you can call the next person, sir. Sir, you have to unmute.
And Dr. Jameel is the next presenter, I believe.
Yes, Dr. Jameel.
Dr. Jameel is already there, so he can start with his laparoscopic management of a huge hydatid cyst. Dr. Jameel, over to you.
Thank you, sir. Thank you for your kind introduction. Good afternoon, ladies and gentlemen. Good afternoon, ladies and gentlemen. My topic today is laparoscopic management of giant hydatid cysts of the liver. The way I would like to do it is I would want to first play a video of a laparoscopic demonstration of excision of hydatid cysts in the liver, and then I would want to cover some theoretical aspects related to hepatic hydatid cysts. Our patient was a 17-year-old lady whose only symptom was that of upper abdominal discomfort for about 3 years, mainly on the right side. She had no jaundice, fever, or vomiting, and she was quite fit and well. There was nothing much on clinical examination. The blood tests were normal. The only abnormality was a cystic lesion in the right lobe of the liver on an ultrasound. A CT was recommended, which we did. And as you can see, there's a large hypodense lesion in segment 7 and segment 8 of the liver on the CT. So based on that, a diagnosis of hydatid cyst was made, and we decided to proceed with laparoscopic excision. So the port positions are as you see in the schematic representation there: camera at the umbilicus, 3 vertical ports, and 1 stab incision in the right upper quadrant for the aspiration. So once I went in, I was able to see the hydatid cyst in segments 7 and 8. And the first thing that you do in this operation is placement of hypertonic saline soaked gauze pieces all around the cyst. And that's to make sure that any spillage is being taken care of. And then we aspirated the cyst. And interestingly, the fluid that came out looked a bit murky, as you can see there. That's an indication that the cyst is either an inactive cyst or it's probably in the transition zone. So once we've aspirated the fluid out, we instill the cyst cavity with hypertonic saline. And the general recommendation is that you wait for about 5 minutes in order that the scolicidal agent takes care of the contents within the cavity. Now, after you've waited for a while, the cyst is opened and a sucker is carefully passed inside. The fluid is aspirated, and throughout this period, utmost care is taken not to spill any fluid out into the peritoneal cavity. The cyst contents are aspirated, and the cyst wall is gently excised using energy device. As one might know, the hydatid cyst has got 3 layers. It's got an ectocyst, an endocyst, and a pericyst. Ectocyst is the laminated membrane, endocyst is the germinal epithelium, and pericyst is basically the host's response to the pathology. So what we intend to do here is not remove the pericyst, because that's not generally advisable in view of the amount of bleeding and biliary injuries that might happen when you do that. So what we are interested in is removal of the ectocyst and the germinal epithelium, which is reported to be much safer and has a very good outcome in terms of recurrence rates and so on. So the laminated membrane is coming out. As you can see there, the laminated membrane is a bit yellowish, or rather yellowish brown, and that is an indication that the cyst is probably inactive. And the fact that it's coming out easily from the underlying structure is also an indication that it's probably detached from the surface, which is in keeping with the fact that the cyst has probably gone inactive or is in the transitional stage. So all the pathology is removed from the umbilicus, but then the entire cyst is usually not emptied in just one attempt. It requires more than one attempt. So another plastic bag was introduced into the peritoneal cavity, and the procedure was repeated. Obviously with utmost care not to spill any contents out. So the entire cyst cavity was emptied, and once that is done, the cyst wall is excised too. So this is what we call as de-roofing. So the entire cyst, the one that was covering the cyst, has been taken out, and now we've got the whole area bare open. Now at this point, it's recommended you take the camera right into the cyst and have a look. I mean, you want to do this to look for 2 things. One, you want to make sure that all the disease process has been eliminated, and number 2, you want to make sure that there are no cysto-biliary communications. So once you've ensured that has happened, you get the swabs also into the bag, and all of it is taken out with the umbilical cord. Now, again, another minor point to note: the swabs also have to be put in the bag and taken out. You don't want to just remove the swab through any of the ports, because that could be a source of infection too. So all of the contents and the swabs are taken out from the umbilical port, and that more or less completes the operation. The area is thoroughly irrigated with saline, and what I normally like to do is take a big portion of great romentum, take it right up to the area and pack it thoroughly, and place a drain in the right upper quadrant. So the postoperative period for this patient was entirely uneventful. The drain was removed on the second day, and the patient was placed on albendazole. There's another patient that I want to show you here, which is slightly different to the one that you've just seen. Big cyst in segment 5 and segment 6 of the liver. The thing that was different in this patient is that as soon as we put the scope in, there was a lot of omental adhesions to the undersurface of the liver. These adhesions were slowly brought down, a combination of blunt dissection and harmonic dissection, and once the ectocyst has been thoroughly exposed, the same sort of procedure was adopted, which is placement of the hypertonic saline soap gauzes all around, and introduction of the needle. Now, unlike the previous case, the fluid that came out of this hydatid cyst was quite clear. It was clear like water. Now, that should ring the alarm bells, because active cysts and daughter cysts, the fluid inside them is usually quite clear like water. So you've got to be extra careful in this patient, because there is an indication that there might be plenty of live cysts inside. So the same procedure, we waited for 5 minutes, and then we go ahead with the opening of the cyst, and suction of the cyst cavity, and there you see a beautiful whitish laminated membrane coming out. Now, these are active cysts, and it's important that you try and use a non-tooth forceps or a bowel graspers to lift them up so that they don't get torn during the process of taking them out and placement in the bag. And it's a slow maneuver. It has to be a gentle maneuver. Try and not take them out in piecemeal. Try and get them, in whole lumps if you can. And you got to go inside the cyst. As you can see there are a number of daughter cysts. Now, it's virtually impossible to get all the daughter cysts in a bowel grasper or any non-tooth graspers, because they can be quite big. They can be 2 centimeters, 2.5 centimeters. So what is recommended is you break them, but then you break them within the cavity, suck the fluid out thoroughly, and then remove the laminated membrane, the daughter cyst, and then place them in the bag. So the last bit of this procedure is excision of the cyst wall completely, and thorough inspection of the cyst cavity, and the entire thing is taken out through the umbilicus. Great romentum is placed as before, and these are all the cysts that came out. Patient did absolutely fine, and he was discharged in a few days' time. Now, that's as far as my video goes. I just want to cover some theoretical aspects of hydatid cysts. We know it's a parasitic infection. It's caused by Echinococcus granulosus, which is also known as dog tapeworm. It's endemic in certain parts of the world, and even in India, there are certain states which are more likely to have hydatid cysts than the others. The definite hosts are the dogs and the canines. Sheep and other domestic animals are intermediate hosts. Interesting, the humans are only accidental intermediate hosts. Contrary to popular belief, humans don't get infected by they don't acquire the disease by eating the meat of the infected animal. Rather, it is acquired by consumption of food and water. It is infected by the feces of the definite host or by direct contact with a definite host through form of abdominal pain due to capsular stretch in the liver, or it could be jaundice because of biliary obstruction. Rarely they can have fever or chills when the cyst gets infected. An upper abdominal mass is also rarely felt. Laboratory data are usually not very helpful. They're all very non-specific, and most of the time the diagnosis is done by either an ultrasound or a cross-sectional imaging. Way back in 1981, there was this classification proposed, which goes by the name Darby classification. It's an ultrasound-based classification. There are 5 types of cysts. Type 1 is a pure fluid collection. Type 2 is when there is a split wall. Type 3 when there are septa in between. And type 4 and type 5 are basically inactive cysts, where there is a heterogeneous appearance or this calcification in the cyst wall. WHO also came up with this classification in 2001, and this one is more of a functional classification. It says CE1 and CE2 are the active ones, wherein there is a unilocular cystic lesion. CE3, A, B are the transitional ones, where the ectocyst gets detached from the underlying surface and causes something called a water lily sign, or if there is a solid matrix interspersed with the daughter cysts. And the CE4 and the CE5 are basically dead cysts. That is when there's a lot of heterogeneous material within the cyst, or if the cyst wall gets calcified. Management is basically 3 types of management: percutaneous, medical, and surgical. And there are specific indications for each of these. When it's widely disseminated, when they're small cysts, when they've ruptured already and causing spillage, or if they're poor surgical candidates, these patients have to be offered medical treatment. And medical treatment is also offered in combination with surgery and interventional procedures. And the recommended medicines currently are albendazole and praziquantel. There's not any national or international consensus on the duration of albendazole, but generally speaking, it's given over a period of 3 months. Percutaneous treatment also has been reported, and it comes, there are a number of acronyms which have been reported in the literature, but the most common of which is PAIR, which is basically puncture of the cyst, aspiration of all the infected contents, injection of scolicidal agent, and then re-aspiration. Again, there are specific indications for these. Again, there are specific indications for these, and they have to be small cysts, less than 5. It's ideal for people who don't want surgery or in whom surgery is contraindicated. However, it's quite important to understand that percutaneous treatment comes with the risk of anaphylaxis. It comes with the risk of chemical cholangitis, particularly if the cyst is in communication with the biliary tree. Lastly, surgical treatment. There's total cystectomy, pericystectomy, which is basically excision of the entire pathology, but it's not recommended because of the problems of bleeding and biliary injury, and therefore other procedures like partial pericystectomy and captionage and omentoplasty have been described. But if the cysts are multiple in the liver, and if partial pericystectomy for each of the cysts is not going to be practical, then a liver resection, either an anatomical resection or a non-anatomical resection, is proposed. Way back in 1994, the first laparoscopic treatment was reported. Since then, it's been a very popular technique. Lots of papers about it. In laparoscopic surgery, also a total pericystectomy is not advisable. The more common and the more and the generally advisable technique is the deroofing and the drainage and the omentoplasty, which is the technique that you saw in the video just now. And there are also other specific systems that have been designed for laparoscopic management of hydatid cysts, and one such system is the Palani-Velu hydatid system, which goes under the abbreviation PHS. In summary, I mean, the best procedure to be done laparoscopically would be a deroofing and an omentoplasty, and that's the video that we have just watched. Thank you very much for your patient hearing.
Thank you, Dr. Jameel, sir, for an excellent presentation. Dr. Jameel, sir, have you ever seen a case with a hypersensitivity reaction or anaphylactic reaction with the hydatid cyst? What is the literature evidence showing that how many percentage cases are there?
Thank you. I haven't seen it. I haven't seen one myself, but I have read about it. and I have heard colleagues experiencing such episodes in the operating room. But generally speaking, it is not as much as a problem as we tend to worry about, particularly as surgeons. The literature says that anaphylaxis and chemical cholangitis are more common in the pair technique as opposed to the laparoscopic and the open technique.
Thank you very much, sir. Thank you for. I think we are running short of discussion time. Yeah.
Okay, Jameel, how common is a recurrence? Because the control is less as opposed to an open procedure.
The recurrence
if you're
rate
doing it
the recurrence rate quoted in the literature for laparoscopic deroofing and drainage is about 20 to 30%, sir.
Dr. Jameel, sir, wonderful presentation. Is there a role for a preoperative albendazole, and how long you give before? Is there? Literature says.
Again, as I said, there is no uniform consensus on this issue. We are generally guided by the advice of the infectious diseases department in our hospital. Yes, there is a recommendation that these patients should have pre-op albendazole before they come around to having surgery. But then many of these patients don't have it, and yet we still go ahead with surgery and put them on postoperative albendazole for a 3-month period. Usually it's about 28 days, and then a couple of weeks interval, and then the cycle is repeated overall for about 3 months.
Thank you, sir.
Thank you.
Call the next speaker. Next speaker is Reddy. Dr. Senthilnathan P. Welcome, sir. You can start with your presentation.
Welcome, Senthilnathan. You can start your presentation.
Thank you, Professor. Can I start the sharing?
Do it yourself from your computer. There is a green screen. Go ahead and do.
Yes.
You can see it now.
Okay. Good afternoon to all. At the outset, I'd like to thank the organizers of Indo-UK Surgeons Meet, IAGES, as well as the Royal College for inviting me to this wonderful platform and sharing my experiences on laparoscopy for chronic pancreatitis. You all know that I bring greetings from GEM Hospital.
Can I make full screen?
Yeah.
Hello. Can I make full screen?
Chronic pancreatitis, as you all know, is a definitive entity where there is a persistent abdominal pain with an evidence of exocrine and endocrine pancreatic insufficiency. More importantly, what we see as chronic pancreatitis in India, especially in South India, is completely different picture than what we see in the Western world. We have chronic obstructive calculus pattern, duct is dilated, multiple large stones are there. So our treatment modalities also varies accordingly. The general consensus for the management
can you press the play button so that your screens get bigger? You know there is a play button on top of your screen. Just press that and that will make your... Now it's okay.
Yeah, okay. Sorry. Now the general consensus for the pancreatitis is we should attack it early before the complications set in, so that we can salvage the pancreas. This is one of my favorite slides, especially for this topic. As you can see, there are very many ways of achieving the treatment aim, which is pain relief. It can be open surgery, it can be endotherapy, it can be pancreatic enzyme replacements, or my favorite topic, laparoscopic surgery. But whichever the option you choose, depending on anatomy, pain relief has to be long, sustained one without any relapse. When we come specifically for surgical intervention, it has to be mainly for pain. The other indications like include coexisting malignancies, biliary obstruction not amenable, or duodenal obstruction not amenable for endotherapy, symptomatic large pseudocyst and splenic artery aneurysms, and these are the indications for surgical interventions. And please bear in mind, diabetes and steatoria are not per se indications. As I told you, the timing of surgery has to be early to prevent and to salvage the pancreas, and also to have low intervention rates. Choosing a surgical procedure, whether it is in laparoscopic or in open, requires a lot of anatomical detailing. Large ducts obviously requires a drainage procedure like a Frey's or a pancreatitis, which has got a better outcome than the small pancreatic duct associated chronic pancreatitis, where we have to force to go for resection procedures and the results are comparatively inferior. We also choose the procedure according to the presence of head mass. If it is there, we have to either go for Whipple's or a Frey's procedure if we could able to exclude the malignancies. One thing which I practice even in open surgery is please don't operate an acute episode, and this holds good to even more valid when we go for laparoscopic approach. And more you resect, the better would be the pain relief. That's been shown in the multiple studies where Frey's is always better than just a lateral drainage. As I told you, exocrine and endocrine function have an variable results, and our treatment modality, especially surgery, should not be determined by the presence or absence of either of these symptoms. Coming to the laparoscopic for chronic pancreatitis, I have to confess it's a no man's land. There is hardly few case series, and in India we have a couple of case publications, and one from Calcutta from Om Tantria's group, the other one from Orissa from Manas Sahu, and apart from that there were hardly any few series, not only in India but also from the world. I'll start with the limitations of laparoscopy, and then I try to show how we overcome those limitations. Identifying the stricture is difficult because when we open the duct at one point, we thought we have done that one. No, it is not. We need to open those strictures so that the entire duct, right from the head to the tail, has to be open for proper drainage and proper pain relief. If you have an undrained segment or undrained duct, then probably that will contribute to postoperative pain. And the other thing is the other limitations of laparoscopy is proper identifying the stricture. Here, as you can see, opening the duct. Imagine this particular area, if you don't drain this one, this is an abscess within the dilated system, and we need to suck out, we need to identify the stricture. You can see the stricturous portion when we identify it carefully, and then we go for complete drainage. To achieve this, laparoscopic ultrasound, especially in identifying the pancreatic duct, I would say that's the rate limiting step. We generally try to put a needle and then see. If it is not coming in few attempts, then probably we need to use an laparoscopic ultrasound to identify it. The other key area where laparoscopy has not picked up is side branches, especially the unsnake drainage, which is very crucial for the success of this procedure. Is very difficult, as you can see. This comes very later in our learning of the laparoscopic surgery for chronic pancreatitis. As you can see, the stone got stuck firmly in the side branches, so we need to open those side branches properly. The other argument against laparoscopy is there is no adequate head coring. As you can see, this is an open picture. And as I can say confidently that as our NASA for 2020, we can go for the same amount of head coring. Only thing is that we have to be very careful, pre-coagulate the tissue. This is, you can see, we have to slice those heads in layers, not a complete head coring in one go. Slowly, we deepen the well of the head so that the complete head is cored out. This has to be done in small bits, like the beetle nut, as Dr. Ramesh puts it. It has to be stripped, or it has to be removed like shaving of the beetle nut from its main content. The next is long anastomosis from head to tail. We need to require about 10 centimeter, 12 centimeter of anastomosis. Sometimes it's difficult. Of course, yes, it's difficult. We have to have experiences in laparoscopic suturing. There are certain areas where we don't operate by laparoscopic at all. like a small duct, as I told you, for obvious reasons. Pseudocyst complicating chronic pancreatitis because it requires wide adequate drainage. The third thing is pancreas completely replaced by stone because it requires digital clearance, and malignancies. You can see there is a malignancy sitting adherent to the stone, so we have to be very careful. It all started with a negative note. Michel Garnier and Pomp said there is no benefit for head resections, followed by a few other authors quoting, these are all for resections in undilated duct with a large head mass. These are all alcoholic pancreatitis, not calcific pancreatitis. What's ideal for lateral pancreatitis is just a dilated duct along with stones. And if it's a head predominant disease, we can add Frey's procedure, which we often do it now. I'll straight away go to the technique. As I told you, the rate limiting step is pancreatic duct identification, and I also told how to identify that one. We need to nudge the stones from all the side branches, if it's possible, and from the main duct, so that entire duct is open, flayed, so that there is no recurrence. Stone clearance have to be very meticulous. Here, as I can see, sometimes it can break. You have to open it adequately, slowly nudge it with the help of suction apparatus, with the help of Maryland, with the help of a bowel forceps, so that it's like delivering a baby without damage. We have to deliver it, especially deliver it the entire stone without piecemeal. So this is a short video combining all the things. As you can see, yes, opening, gaining exposure to the lesser sac is very crucial. Then I'll just go back. This is, yes, we identify the pancreatic duct using Virus needle, or if it's a large duct, or if it's a slightly less dilated duct, we use it using a spinal needle. Then we remove the stone, as you can see. Once we enter it, we have crossed the main rate limiting step. As you can see, it's a very, very, this is the Frey's procedure, meticulous procedure, long procedure. We have to be careful, slow and steady when the race holds good in this particular procedure. As you can see, head is completely cored, wide open, flayed, so that the complete stone clearance is achieved. Even parenchymal stone clearances can be achieved by stone clearance. And then, as you can see, it's a multi-quadrant anastomosis, because we start from the tail, come to the head. Sometimes we need to change the camera as well as the right-hand suturing trocars. We need to change, especially as you can see, the reverse suturing is very crucial in the head portion. And also sometimes we can hit the blood vessels. We have to suture it during the bite taking in the head. So we have to be very careful. Sometimes stay sutures have to be put in the head to avoid bleeding. So that's about the video. As I told you, very few literature support, and I can quote from our experience as well as from the others one. And since this is a UK Indian experience, the first UK experience came as late as into 2014 only. And we had our first experience publication in the year 2006. And then later we came out with this largest published series in the world, which has got about 39 patients for laparoscopic LPJ. Till now, this is the largest series. And if you look at the pain relief, it's about not much difference between the laparoscopic and the Frey's procedure. Pain relief is in the order of 90%, which compares favorable with that of the open Frey's as well as lateral pancreatic or modified Puestos. This is what I was shown in this particular study. Our study of 47 patients with the operative blood time of comparable operative time, blood loss is comparable with the added advantage of laparoscopy. That's what we could able to show in this particular series. Till now, this is the largest series in this particular road less traveled field where not much of a publication exists. If you look at the pain, very important, that's a very important marker of the quality of surgery. our results have shown that not only short-term but also long-term pain relief is in the order of 85%. Again, that along with the weight gain, that shows that laparoscopic works favorably with chronic pancreatitis. Only thing is that we need to have proper selection, proper experiences with this procedure. We also published our experience with the single incision laparoscopic pancreatitis in highly selected patients a few years back. That also got published. So overall, with these 3 publications, we could able to at least convince a few of them that yes, laparoscopy for chronic pancreatitis is here to stay for a definite subset of patients. So I'd like to conclude by saying that laparoscopy for chronic pancreatitis is definitely technically demanding. It can be used in highly selected patients, and whatever the limited experiences with literature shows that equal results with open approach, with the added advantage of minimally invasive benefits of minimally invasive surgery. Thank you, and once again, thank you for the opportunity to share our experiences with chronic pancreatitis. Open to questions.
What your main etiology is alcoholic pancreatitis, or is it genetic in children or adults? What is the main etiology of pancreatitis in your case? Is it
majority
alcohol
or
abuse?
Sorry, sir. Majority or tropical calcific pancreatitis. Alcohol.
This is a separate entity from alcoholic pancreatitis.
Yes,
the tropical calcific.
Majority. We do operate on alcoholic pancreatitis. I would say the percentage wise, it's in the order of 15 to 20% alcoholic pancreatitis.
Congratulate you. This is a very demanding operation, which is done very well, and pain relief of 88 to 90% is remarkable, because the main problem of chronic pancreatitis is basically pain.
Yeah, that's why we were very selective in our approach. We don't select minimally dilated ducts. We don't select patients in acute episodes. It has to be very highly selective ones. On any given day, I'll be happily operating on a laparoscopic Whipple's than on a laparoscopy for Frey's or lateral pancreatitis, because we are unsure about the procedure till it is get completed, unlike Whipple's. I know, yes, it's technically demanding.
Well, I think we can move to the last speaker now. We're running out of time.
Thank you so much.
Desh, are you there?
Am I audible?
Yes, you are. Rajesh, over to you. Dr. Rajesh is going to talk on colorectal cysts in adults in the laparoscopy era.
Yeah.
Over to you, Dr. Rajesh.
Yeah, thank you so much, and a very good afternoon to all of you. And let me also welcome you all from the organizers end to this INDO-UK conference, which is being attended by more than 2,000 people. And thank you all for being there. Carrying on with my talk is going to be by and large a theoretical kind of debate in my own mind, whether the colorectal cysts, they give you the rewards when operated by laparoscopy as compared to the challenges which are posed to the surgeon who is trying to get into laparoscopic excision of colorectal cysts. So trying to create the perspective of this particular issue, the first colorectal cyst description came in 1723, long back, almost about 300 years back, and first operative intervention almost about 125 years back. The first operation was done, hepaticoduodenoscopy, in 1924, and the first successful laparoscopic excision came in 1995. What I want to emphasize is, despite being 25 years of laparoscopy in colorectal cyst, it has not become a very common operation, particularly in adults. In children, certainly, many centers are trying to take it up, but it appears to be a different ballgame in children and in adults. The Until 1960, when I tried to look at the publications, until 1960, there were just about 124 articles. But after 1960 to till about 2017, there were 2,500 articles almost. But if you look at the publications, most of the publications have come from Japan and then China, very few from India, most from the Western countries like USA. And that's perhaps because the publications have been more from there. The disease tends to be more prevalent in this part of the Asia, in these parts of the Asian countries. It's very common in Japan, China, I would say relatively common, and in India, and particularly from the state where I come from, colloidal cysts perhaps are quite common. There is a definite geographical and a gender variation, and the female preponderance is almost about 4:1, and some studies suggest 9:1 also. And that is actually the main issue as to why laparoscopy should be good, because most of these patients who come to us are actually young females who deserve some kind of good cosmetic along with a very good outcome. So,
Jayesh, can you press the play button, and that will make the its full screen and bigger, better for us.
I'm sorry for that. Yes,
it's okay now. That's the view we want to see.
Yeah. Okay.
You can use your right and left arrow to go forward or back, just in case.
Yeah. Okay. So, because it is more common in females, there is definitely some indication towards laparoscopy. In adults, it is different from children. The presentation is usually non-specific. There is a right upper quadrant abdominal pain, which is the presentation in most. Jaundice may be there in some of these patients, and they will often present with acute pancreatitis or cholangitis, and sometimes they are picked up with gallstones on imaging. If you look at the operative considerations in pediatric vis-a-vis the adult age group, the morbidity in adult patients is about 14%, 14 to 15%, which is quite a bit of morbidity, and it is definitely higher than the pediatric age group. And it has been now shown conclusively that complete excision with a bilioenteric anastomosis, preferably a Roux-en-Y, should be the mode of treatment for these patients if the intrahepatic component cannot be taken out completely. If the intrahepatic component in some rare cases is localized to one lobe of the liver, then the liver also needs to come out. Now, the principal components of surgery, they include complete excision of the extrahepatic biliary tree and removal of not only the extrahepatic cyst, but also the area of relative stenosis between the common hepatic duct and the intrahepatic biliary radicals to achieve a free biliary drainage. And therefore, a good interpretation of the MRCP is important. Clearance of the intrahepatic ducts of debris and stones, because many a times protein plugs form and they are the reason for cholangitis and the symptoms. A good RULU, which is approximately 45 to 50 centimeters, and which is ideally taken retrocolic. Then creation of a wide stoma, and if need be, the stoma has to be widened either along the left hepatic duct and sometimes also along the right hepatic duct to create a good stoma, a good hepaticojestomy to prevent stricture later on. And of course, the hepaticojestomy, which is the most difficult part of the operation. I'm just trying to give you the perspective of laparoscopy versus open. If you look at this publication came in JAMA Surgery about 5 years back, and that was actually a kind of a cumulative study of almost about 400 patients which had been published in the literature in the open surgery, and they reported that the perioperative morbidity was very high in adults and to the tune of 15 to 35%. In pediatric age group, it was about 15%, but in adult age groups, the morbidity was about 35%. But this document, which was actually a multi-institutional accumulation of data from various American centers, they also showed that there was a high incidence of cancer, about 26%, and a stricture after cystoenterostomy, which means that most of the short-term and the long-term complications actually revolve around the anastomosis, the biliary leak, and the later biliary stricture, and in some patients, if the cyst is not completely excised, maybe a biliary malignancy. If you look at the published literature of laparoscopic there are almost about 10 good series of laparoscopy with various experience, and almost all of these series, they show about 5 to 15 to 20% of morbidity, and I could see also one mortality in one of the patients there. But overall, all of these series have somehow mentioned that if you compare the data, the morbidity and the short-term outcome was perhaps better than the series that I just mentioned, which came in JAMA surgery, which was on these results of the open surgery, and they said that laparoscopy is better. Now, overall, based on these publications, what can be concluded is that laparoscopy is safe and technically feasible. There is a shorter time of recovery and the hospital stay. There's a longer operative time for sure, and there's no difference in post-operative complications, and there's definitely a decreased blood transfusion in laparoscopy, as has been seen in various other operations of laparoscopy also. Now, if you look at the laparoscopic learning curve, it is important because in pediatric age group, it is published at about 37 cases in one series. But in the adult cases, if it's an HPB surgeon who's into routine laparoscopic surgery for HPB, perhaps it is about 20 cases. That's just my guess based on my own experience. But important determinants of the intraoperative time duration include the duration of symptoms, the vascularity around the cyst, the portal arterial biliary anatomy, the pancreatic interface, the preoperative biliary interventions, the stent, which makes it difficult, the type of the cyst. Once in a while, we do get to see big cysts, familiarity with the HPB surgery, BMI of the patient, and of course, the learning curve attainment. I'll just try to show you some videos like the important steps. It's very, very important to go down right up to the waist of the cyst and clip it right there into the cup of pancreas, dissect it out as much as possible. In fact, you have to get down to the waist, but stay away from the junction with the pancreatic duct, and therefore the MRCP is vital in all of these patients. And although, of course, that's my opinion, but I don't get to see too much of ABBDJ, as has been reported, particularly from the Western literature. When you go up there near the hilum, it is important to make a good wide stoma because that prevents the post-operative stricture, short-term and long-term. And whenever possible, as I mentioned, the narrow cystic area, the narrow band between the common hepatic duct and the intrahepatic channels has to be dilated, and the hepatotomy, hepaticostomy has to be extended along the left hepatic duct so as to make a good wide stoma, and whenever possible to achieve an anastomosis which is at least about 12-20 millimeters or 2 centimeters. The incision, the pancreatic dissection is very important because, and it's always handy to divide the neck of the cyst near the hilum first, unlike the open surgery wherein we divide the lower end first, divide the neck near the hilum, retract the big cyst towards the anterior abdominal wall, use the energy source, keep it on the minimum mode so as to achieve more coagulation. Don't use shearing force. Don't swipe. Try to swipe. You can sometimes swipe the pancreas in the children, but not in the adults because it's badly adherent and it tends to bleed. And there are bleeders all around because of the recurrent pancreatitis these patients have had, or recurrent cholangitis that these patients have had. And you can see, but it is important to dissect out the entire cup of pancreas in all of these patients, because that's how you go down deep. And then importantly, it is also important to create a good rule loop by the retrocolic tunneling. You can see the dilated cyst which is there, the duodenum which is there, and you just have to make a neck just above the duodenum, and therein you will find that avascular plane which will lead you right up there towards the inferior border of the liver, and you can actually carry your rule loop through this. And then of course, when you do the anastomosis, I've tried all sorts of anastomosis in the last almost about 13 years that we have been doing these operations. And if you can see, the direct, the single layered continuous anastomosis in a good wide stoma with 30 PDS also works. I've used VLOC also. I've used posterior layer interrupted also. And at the moment, if you ask me my choice, I do the posterior layer interrupted and the anterior layer continuous. It is always important when you take the pricks on the posterior wall to prevent the prick to the right hepatic artery, which is usually going posterior, or you make it posterior after dissection if it is going anterior during the dissection, and come up with a good anastomosis. So after taking 2 or 3 bites, you can actually pull the thread and take the anastomosis up. And once it gets good approximation with the bile duct, it actually makes the job easier. Because then you can always have the entire vision under you, and the rule loop now stays there. Because one of the important issues while you do this anastomosis is that the rule loop tends to keep falling, and once you have taken 2 or 3 bites, it stays there, and then the entire anastomosis can be completed. It is always important to secure the sutures well, the corners well, because those are the sites of leak. And although, of course, if you're taking a single thread continuous, it is easier to take the corners. Otherwise, with interrupted, it is always a good idea to, as we do in the biliary strictures, to take neo corner stitches when you start doing the anterior layer. A mucosa to mucosa, good wide 2 centimeters anastomosis is the key to all the bilioenteric anastomosis, as we all understand. So, what are the determinants of outcome? The determinants of outcome include the intraoperative determinants, whether we have done the complete excision or not, whether the bilioenteric anastomosis has been good or not, whether the rule loop has been long or not, and of course, whether the rule limb has been taken retrocolic. And of course, the long-term determinants include the anastomotic stricture, the readmissions, recurrence, and the malignant change. So, based on these reports, is the laparoscopy better? It is certainly better because it gives small incisions and a magnified surgical field, so more comfort for the surgeon to operate, provided the learning curve has been achieved. There is a similar morbidity and mortality which has been shown by various publications from various authors. And there is improved cosmesis in these patients who are young females most of the time, and they certainly desire the best outcome for their congenital disease that they have received. Based on these, I can classify what are the challenges. The challenges are, because it is an infrequent disease in adults, one may not have the caseload which will help them gather the practice or the learning curve. It is more difficult in adults as compared to children, in which the dissection is easy. The reconstruction is involved, and therefore suturing skills have to be good. There has been a deficient percolation of laparoscopy amongst HPB surgeons, but in the time it is going to improve, I am sure. And the simulation models as yet are not available for operations like hepatico-enterostomy. And trying to circumvent the challenges, how can we circumvent these challenges to optimize the outcome? We can break up the operation into steps. The portal vascular imaging preoperatively, just the way we showed in the morning for our Whipples, preoperatively, it always reduces the operative time. One should venture into HPB procedures as a whole, and not only biliary or pancreatic or liver procedures. Suturing practice on indigenous simulation models helps. Rule loop creation on non-HPB procedures help in the learning curve, and we learned our rule loop creation on the bariatric operations. Robotics may certainly help in suturing for robotic surgeons. Institutional collaborations can also shorten the learning curve, and collaboration with pediatric surgeons is likely to help. We have had now a good experience in the last 14 years, almost about 166 cases, out of which 139 were laparoscopic, pediatric 22, adults 117. And those have been our publications. And particularly if somebody is interested in looking at our technique, one can go through this textbook, which also has a video chapter on how we do the cold doctor test in our unit. And you can see this kind of outcome is very, very rewarding in a young female. Thank you all very much, and I bring greetings to you from my unit at Jaipur.
That was wonderful, Rajesh. The only problem we have is we have run out of time. Otherwise, there would have been a lot of questions on it. What was the incidence of malignancy in the adult population you had?
Actually, I have never come across a malignant patient on whom we were trying to operate and diagnose as a choledochal cyst. Wherever there was a malignancy, we have been able to pick that up preoperatively itself. And we have now quite a few patients who have had carcinoma gallbladder. I think about 7 patients that we have operated on carcinoma gallbladder in the setting of a choledochal cyst. And of course, we have operated 1 hilar cholangiocarcinoma also, and 1 intrahepatic cholangiocarcinoma also, because choledochal cyst perhaps is very common in this part of our country, Rajasthan.
I think we had a very useful afternoon session, starting with Dr. Prasanna Reddy, who talked about PNET, and I think he mainly mentioned was that more awareness among the physician colleagues and easy availability of the imaging modes have led to an increasingly recognition of the rare disease called PNETS. We had Dr. Jameel talk about hydatid cysts, and I think it's amazing that a big hydatid cyst can be dealt with laparoscopically without a spillage, and he adequately showed the use of the bags to extract it and be very gentle with the laminated membranes. Then we had Senthilnathan, who showed beautiful videos of his technique of lateral pancreatico-jejunostomy and Frey's. I think even if it's a challenging procedure, it is worth doing it laparoscopically if one has got the skills available. And finally, we come to the adult choledochal cyst, Rajesh, which just has mentioned. I think all of these were very useful. And I need to thank Jayalal and Senthil in collaborating it. Jayalal, have you got anything to say? And so, Senthil, we have run out of time.
So, we have run out of time. Thank you very much. Thank you. Pleasure meeting you, sir.
It's pleasure meeting you. Over to the organizers for the next